All right, everyone, welcome today to today's Let's Talk Parkinson's. I'd like to introduce Dr. Melissa McConaughey, who is a clinician and an educator. Melissa is also a specialist neurological physiotherapist. She's the CEO of Advanced Rehab Centre, also known as ARC, which is a multi-site and community neuro rehab service in Sydney. And she's also the founder and CEO of PD Warrior. PD Warrior also present the Insight Conference each year, which is an online Parkinson's conference. And this year it will be the 9th year running. And today Melissa's going to talk about staying safe, staying strong, and staying steady in Parkinson's. So over to you, Melissa, whenever you're ready.
Thank you so much, Stacey. Absolutely delighted to be here. I'm coming to you from Camaragal land, and I'm going to probably spend about 30 minutes talking, and then, as Stacey mentioned, we'll have time at the end of that for a Q&A. I will just share my screen first, just to make sure that you can all see that. So the reason I've selected this topic to talk about is because I do get a lot of questions around falls prevention, staying safe and strong, particularly around the later stages of Parkinson's. PD Warrior and much of what my time has been spent on more recently is in the early stages of Parkinson's. But a lot of the concepts around neuroplasticity and exercise prescription definitely hold true for later stage Parkinson's. So what I will be talking about is very much in exercise and exercise behaviours. So I'm just going to be talking about neuro pathways, and I'm going to try and simplify it as much as possible. What happens in Parkinson's with the dopamine deficiency is it has a really big impact on what we call the extrapyramidal system. And a lot of neuro rehab is spent around stroke rehab and things that create a kinematic deviation where somebody might be paralyzed on one side of their body, for instance. Parkinson's is almost the complete opposite of that. And when we talk about extrapyramidal systems, what we're talking about are not the primary drivers of movement. We're talking about the components of movement around coordination and refining really nice quality of movement. So it's very much around the quality of movement that we talk about in Parkinson's. And a lot of what is impacted in Parkinson's because of that dopamine deficiency is the scale, the amplitude of movement, as well as the effort and the power required for functional movement. And so that's very much around the extrapyramidal system. What's also impacted in the extrapyramidal system and the dopamine deficiency is postural tone. And so what that really impacts is the ability to stay upright, to have adequate midline alignment. And what you might notice in Parkinson's, particularly in those in the later stages of Parkinson's, is a bit of a deviation moving forward. So there can become this postural adaptation where people start to move forward. It might be that there's a bit of Camptocormia or Pisa syndrome where there might be a lateral movement. Any deviation away from midline is typically associated with that extrapyramidal system. So not to go into it too much, but just knowing that Parkinson's is very much around trying to improve the quality and the coordination and the motor control components of movement. And that's what I'm very much going to be talking about as we go through the presentation. And with the later stages of Parkinson's, obviously there's lots of clinical considerations around the medication that people might be taking. But what I'm going to focus on very much today is around falls and falls risk and how to navigate that. Freezing of gait, because this is a very common component of the later stages of Parkinson's. Managing fatigue, because this has a huge influence on how well you feel in yourself, how motivated you might be, how engaged you can be, how you perceive pain. Perhaps if you're absolutely knackered, it might mean that you perceive your pain as more pronounced, for instance. So fatigue management is really important. Talking about some of the cognitive changes that people might be experiencing and how to deal with those. And then with the later stages of Parkinson's, it can also be associated with comorbidities, because people can become much more sedentary in later stages of Parkinson's, which definitely can impact how many comorbidities people might also be dealing with. But it also relates to the later stages of age as well. And we know that in Australia, as people age, at least 1 in 3 people over the age of 65 without Parkinson's will be dealing with a comorbidity. And so we need to take that into Parkinson's and probably look at higher levels of comorbidities as well. And that can be associated with frailty as well, none of which is inevitable. And what I'd really like to go away with today is the fact that the more you can do for yourself in terms of exercise, lifestyle, exercise behaviors, keeping yourself as active as possible, frailty and comorbidities are not inevitable at all. And the more you can do, the more likely you are to offset any of those introductions into your life. So if we touch on falls contributors, for those of you that have seen me present before, I will often bring this slide up because it is very complicated, all the things that can contribute to falling. But the reason I bring it up is because falls have such a big impact on how you get around your day, whether you're confident enough to get out and about and do the things you want to be doing. If you've had a fall, or you've had even multiple near misses, this can have a really significant impact on your confidence. And what we find is if confidence is impacted, then people start to withdraw from social activities, overall activities in general, and the universe can become a lot smaller and sedentary behaviours can become a lot more pronounced. And that's when it can become quite a spiral as well. So confidence is really important. Past falls is really important, and near misses, we call them, because they can be under documented and we may not recognize the contribution of those near misses as well. So falls are a big area that we focus on in the later stages of Parkinson's. Now, if you haven't seen this slide before, or I haven't presented on this before, some of those contributors I'm going to elaborate on further, but I will just touch briefly on postural instability. This is a big one in Parkinson's. So with the extrapyramidal system that I mentioned earlier, it has an influence on postural tone, ability to sustain midline alignment, but it also has an impact on writing reactions. So imagine if you're in a really busy shopping centre, for instance, and there's a lot of noise, there's a lot of people moving around, and someone bumps into you. How able are you to react sufficiently to step out so that you save yourself from falling over, for instance? That is your writing reaction to somebody bumping into you, some form of external perturbation. It's really important that you can do that sufficiently so that A, you don't fall over, but B, you feel confident enough to be out and about. The other thing that will impact postural instability is your perception of body in space, body awareness. And we do know that this can be impaired in Parkinson's. So if you're not really confident or know where your legs are in reference to your center of gravity, for instance, this can also put you off your balance quite a lot as well. So if there are these small changes, that can all have an impact on your falls risk. And these would definitely be areas that we would want to explore as part of a physiotherapy assessment, for instance. With respect to vestibular dysfunction, unfortunately, as we age, we have these little crystals sitting in our inner ear. They can tend to dislodge. It's really common over the age of 65 that people have these crystals tending to float around, and that sometimes means they can end up in the wrong canal. And that can lead to peripheral vestibular problems, which is simply an age-related issue. So we would expect to see that in people with Parkinson's simply as a product of age. But what we also see in Parkinson's is a central vestibular problem, which is more like a processing issue, trying to align where you are and where your body is in space with what information is coming in from your peripheral system, and then what your vision is telling you as well. And sometimes that integration of that information can be impaired, and that can really influence dizziness, vertigo, just not quite feeling right, feeling a bit spaced out in the head, and that obviously can increase falls risk as well. So that would definitely be another area that we would screen for in physiotherapy, and that is definitely an under-assessed area we tend to find. And that can be one of the biggest reasons why people might fall. So it definitely needs to be something that is screened for. I will touch more further on freezing of gait, so I'll leave that for now. And I'm going to touch a little bit more on deconditioning, and autonomic dysfunction we'll talk about a little bit more as well. So safe to say environment, so making sure that at home there's not a lot of trip hazards, rugs that you might stumble over, dogs that might get in the way and you might trip over as well, cluttered environments. All of those things are really important, and I've got some fantastic literature to show at the end of the presentation on how much impact making changes in all of these areas can have on your falls risk, and actually the number of falls that people have, which is really encouraging news to know that we can have a significant impact and outcomes. And then I will just touch very briefly on medication, because medication is really important, obviously, for symptom management, but it can also be a double-edged sword. And we know that levodopa can improve the way that you move, but it doesn't typically improve your static balance. And if you've got dyskinesias, you'll know if you've got them, that can also increase your risk of falls as well. So levodopa medication in particular can actually be a double-edged sword. Safe to say, all of these contributors to falls are areas that we would be looking for in your physiotherapy assessment, and then we would be prescribing your exercise program very much based on the information that we've gathered and what we think is going to give you the most bang for your buck to prevent falls in later stages of Parkinson's. So with freezing of gait, this is really common. Up to 60% of people with Parkinson's will develop freezing of gait within the first 10 years of diagnosis. So it is a big issue. And it can really impact confidence, which I've already mentioned before, and ability and willingness to go out and participate in all the things that you want to be doing. And that's probably where I come from, because if your universe starts becoming smaller, that has such a big impact on your engagement levels, your motivation, your interest levels, and also what's happening in your brain, because your brain responds to all the information that comes into it, and it keeps it rich and lush and thriving within your brain. And so if your universe becomes smaller because you're not confident getting out and about because of freezing, falls, etc., your brain is also very good at pruning off pathways that it's not using anymore. And so it's very, very important that you're constantly challenging your brain with physical and cognitive mental challenges as much as you possibly can. And part of that is getting out and about, which is why freezing of gait can have a big influence on that. So without going through all of these issues here, there is a little image there on the screen, and basically freezing of gait, there's a couple of schools of thought, but the one that resonates with me most from the literature is that as Parkinson's tends to progress, we've got other parts of the brain coming in to support what is going on with that dopamine deficiency. And so we will have pathways coming from cognitive areas in the brain, from the front of the brain. We will have sensory information coming in and those pathways. And what happens over time is, because everything's trying to compensate because of this dopamine deficiency, we get actually what's called a lot of interference. And so instead of having discrete pathways, they then start to interfere with each other. And then that can have a knock-on effect where it impacts freezing of gait. So what might have been automatic to shift weight and take that step forward actually becomes inhibited because of all this merging of pathways. And there's an area at the back of our brain called the cerebellum, which is responsible for coordination of movement. That has a really big role to play in the later stages of Parkinson's because of that dopamine deficiency. Instead of being able to refine movement from the basal ganglia, which is where that dopamine is largely produced, we have the cerebellum coming in, and that really has a big impact on the interference that we experience in freezing of gait. Safe to say, for most people, freezing is improved by levodopa medication. There's a small cohort of people where it may not be improved if you have more of like a very anxious presentation. And you'll know if you've been an anxious type of individual previously, prior to diagnosis, you might notice that those anxiety levels increase significantly. What we tend to find and what is supported by the literature is if anxiety is one of your main non-motor symptoms, that can actually impact your freezing of gait very significantly, and that is not typically responsive to levodopa medication. And if that's the case, there are definitely other strategies that we would adapt in clinical practice. They would be quite different from somebody who does respond to levodopa medication and might need a lot of gait retraining, for instance. But again, that comes back to the assessment process and really unpacking, well, what is it that's driving the freezing of gait so that we can create the most effective treatment program. All right, I wanted to touch on skeletal muscle changes because this is an emerging area looking at why people have this perceived weakness and is there actually anything going on at the level of the muscle. We know the coordination of peripheral drive is definitely impacted, but what we see as people tend to age is what is called sarcopenia. And sarcopenia is age-related weakness. Now, I touched on this at the very beginning of the presentation. Age-related weakness is not an inevitability by any means. It's what happens typically in Western society, but it's merely a byproduct of sedentary behaviour patterns that are adopted as people tend to age. So if you can keep yourself active and mobile, lifting the shopping or carrying the shopping, getting in and out of low sofas and chairs without using your hands, lots of different things that you could do incidentally, you are much more likely to stave off that muscular decline and what they call sarcopenia. And the reason why that is so important is that balance correlates really highly with strength. So if you start to lose strength because you become sedentary, that will have a big impact on your balance. It will then have a really big impact on your ability to do functional tasks throughout the day as well. And that sedentary behavior not only means that your muscles tend to become much smaller, they atrophy. The muscle fibers that you also have, and this is without going into too much detail, but the muscle fibers change as well. And what we typically see is that people that require or do powerful movements like getting out of a low chair, getting out of the bath, getting off the floor, that requires quite a lot of power, and you will typically be drawing on type 2 muscle fibers. If you're not doing those exercises and activities and you're not really stressing your muscles, what we tend to do over time, and particularly with age, is we tend to lose those type 2 muscle fibers. And what we're left with are the type 1 muscle fibers, which are really good for endurance, but they then leave us with this deficit when we need powerful movements. And we need power because we need to step with enough amplitude and enough power to stop ourselves from falling if we have that bump in the shopping centre, for instance. So the type of muscle fibers you have is really important, and the amount of muscle fibers you have is really important as well. And I just listed a whole lot of different reasons why there are musculoskeletal changes. These are as much age-related as sedentary behaviour patterns. There are some changes specific to Parkinson's. So what we might see is more fatty tissue infiltrating muscle as well. That's as much age-related, but there is a component where we see that in Parkinson's specifically. And we also might have instability in the neuromuscular junction as well. And these can be Parkinson's related. But all of these can be reversed, if not completely, to a degree with exercise and the right kind of exercise. So everything that I'm talking about, there is a silver lining. There is stuff we can do about it, but we need to understand it first and unpack it for each individual. Now I've got a little bit of a graphic on the right-hand side there. Now this is an illustration. It's pulled from actual data and actual cross-sectional CT scans, but I just really wanted to illustrate the point. If you had a 40-year-old triathlete, this is a cross-section through the thighs of somebody lying down. So we're looking at the top of their femur, and then you've got all of the thigh muscle bulk, which is the grey tissue around that. And you could imagine in somebody that's a triathlete, they're very active, they're doing lots of strength training, they would have quite a lot of muscle bulk. Versus somebody who's older age, 74, and very sedentary, you can see all that white around the outside. What we would call that is fatty tissue, subcutaneous fatty tissue, but you can see that that's infiltrating into the grey muscle area as well. What that does is it impacts the amount of strength and stability of the muscle fibers that are remaining, but you can see there's a lot of atrophy in the muscle bulk as well. Now, just for illustration purposes, what I've shown you here is a 70-year-old PD warrior. What I want to illustrate is that it's not inevitable that you will have that muscle atrophy or that fatty tissue infiltrate if you keep yourself fit and active. And that does require more than just taking the dog for a walk. That requires progressive resistance strength training. And there's some really lovely data coming out now around how much impact that can have, not just on muscle bulk, but on function as well, improving your walking speed, improving your capacity to remain independent, getting off the toilet seat, all the various things that you will need to do to remain independent and mobile and active and out in the community doing the things that you want to do. Now, there was a question that was sent through just regarding physical activity levels and walking, and is walking enough? And what I want to say here is the more you can do, the better, but it's not enough just to say go for a walk. What we know from the literature now is walking is fantastic and there is definitely a place for it, but walking alone is not enough to give you the best gains from exercise. This was a study that was done in 2021 on about 300 people, and they just looked at overall levels of activity, and they did find, unsurprisingly, that there was a cohort, about 30% of that group, that were very, very sedentary. And the population that were very sedentary, not surprisingly, had poorer balance, poorer functional mobility, poorer outcome measures on multiple domains. And this obviously then meant that their universe, their world, their social participation was much smaller as well. So there is a direct correlation between activity levels and mobility and etc. So it's really important that you do keep yourself as mobile as possible. So yes, there is a place for walking, which is why I wanted to show you this next slide here, which was a paper that was published last year looking specifically at how many steps do you need to do on any given day to reap the benefits of walking. Because I wanted to show this because it's really important that, you know, if walking's all you can do, what you choose to do, there is definitely a place for it and you should be doing it for sure. Now, this was not a Parkinson specific study. This was done on an older age population. Some of them may or may not have had Parkinson's. But what they found was there was a significant benefit to be gained from walking 7,000 steps or more most days of the week. Okay, and what they found was with 7,000 steps over the study intervention period, they found a 47% lower risk of overall mortality, a 25% lower risk of cardiovascular disease, that's heart health, 37% lower cancer mortality, 38% lower dementia risk, and a 22% risk of lower rates of depression. You know, those are really powerful numbers. And if you take anything away from today, the message would be you need to move more. If you've got the time and the capacity, there are also better things you can be doing for bigger bang for your buck with your exercise as well. Now, some of you might also be thinking 7,000 steps a day, even if you know what that means for you on a pedometer or a smartwatch, for instance, may be way too much. And you might be thinking, goodness, I can never get to 7,000 steps. But what they've found is even modest increases in step count matters. So going from 2,000 steps a day to 4,000 steps reduce mortality by a third. So if you have a way to track your number of steps, that would probably be the first thing I would argue. Find a way to measure your steps. You can do it on a smartwatch, a smartphone. You could even get one of those old school pedometers and track it. You need to record it and see where you're going, and maybe reflect on days where you're not doing as much walking. What happened that day? Why perhaps didn't you walk as much? And how can you put some strategies in place to maintain a base level of mobility and walking, and then possibly even look to increase that? So that's what I would say around walking. There is definitely a place for it, but it may not achieve all the gains that we would hope for and expect from rehab. Just to labour the point as well, walking speed is also really important. So I've put a study in here, Middleton and colleagues, but there was quite a big study that was conducted back in the 90s, I think, just looking at the Grim Reaper is what they titled the paper. I'm just looking at your walking speed, because the slower you walk, the more likely there are indicators for morbidity and mortality. And part of this, the speed of your walking will come from your balance and stability on one leg. It'll come from the type of muscle fibers you have in your calf muscles. If you don't have enough type 2 fibers, it would make it very hard for you to have the coordination and strength to have a faster walking speed. It will come from endurance. It will come from lots of different reasons. But if you have difficulty crossing a set of traffic lights because of the timing required, the speed required, that would typically be kind of the line in the sand where we would be looking to increase walking speed, because that would be an indicator of worse outcomes for hospital admissions, mortality, and morbidity. So that would be one way for you to check now how you feel crossing a set of traffic lights. If you feel that's problematic from a speed and timing perspective, perhaps that means you might need to have somebody have a look and see how we can go about improving your walking speed, because speed and number of steps are both as important as each other. And then this over here is just some normative data based on what walking distance we would anticipate or expect for somebody without Parkinson's. And we use this as a normative benchmark, essentially, to look at pre and post exercise intervention to see if we can improve endurance and fitness over time. All right, I'm just conscious of time, but I just wanted to bring up a couple of precautions to exercise. If you're thinking about increasing your exercise off the bat, we are certainly noticing a lot of changes in autonomic function. And what I'm talking about here is your body's ability to regulate its arterial blood pressure. And what that manifests as is either really high blood pressure, really low blood pressure. It can be quite unpredictable, or it can even lead to changes in your ability to lie down and sit up and have a stable blood pressure, which means you might get really woozy. Obviously, that creates a bit of a falls risk. So there's lots of things that we look at in clinic to assess your autonomic function and how well your body, your brain, and your heart can sustain your arterial blood pressure. Because if you're coming into clinic and you've got medication and a stable blood pressure, but you're coming in with a really high blood pressure, it might be that we can't exercise, or we need to have a protocol or parameters from a cardiologist or a GP to make sure that your exercise is going to be safe for you. And likewise, you might come in really low blood pressure with not very many reasons for that. It might be medication related, it might be Parkinson's related, but we need to know about that so that you're not putting yourself at risk of having a falls or a syncope episode as well. And it may not be a balance problem, it might be more of an unstable blood pressure, autonomic dysfunction issue, which is what we would assess for in clinic as well. Just in terms of fatigue, I did touch on fatigue before. We know that with fatigue, sleep can have a big impact. So sleep architecture can be altered in Parkinson's, which means it's harder for you to get to sleep and it's harder for you to stay asleep. And when you are asleep, it typically means you're not getting as much restorative sleep. And all of that can have a very, very big impact on overall fatigue levels. We know that sedentary behavior patterns could also create reactive fatigue. And if your body's asking you to do things and your body's not responding, your brain has to yell at your body to do these things as well. And that can create more fatigue as well within your body systems. So we will often look at your levels of fatigue, and counterintuitively, exercise will help. It will help you to get to sleep quicker, and it will help with more restorative sleep when you are asleep. But not many people feel motivated to exercise when they're knackered. And so this would be all around putting strategies in place to improve your overall fatigue levels and monitor that. So when you start, it's not a boom bust cycle where you exercise and then you're absolutely shattered afterwards and you can't do anything. That would be way too much. So it would be prescribing exercise where you could build on a program as such. But just looking at these graphs here in terms of functional capacity, that correlates well with fatigue levels. And functional capacity is your ability to be independent as much as possible. And what we often look at is if you're well up on this functional capacity curve and independent with all your daily activities, etc., and you have a fall or a period of immobility due to illness or whatever it might be, that's fine. You're still well up on this plateau and you can recover quite quickly. But for those that are more sedentary, more frail, any period of immobility might be the tipping point for losing a level of independence that can't be regained. And so again, when we talk about endurance and strength and all of these issues, it's making sure that we understand the baseline level of functional capacity that you're sitting at so that we can get you back up onto the plateau if you're not already, so that you can sustain any period of immobility regardless of what that issue might be. I've talked about sleep dysfunction. I will move on. In terms of cognitive changes, again, this is just very much around your ability to sustain a task, to not be diverted if you're doing a particular activity, to be working through problem solving as well, so that when you're home working independently, you can be safe and you can be effective. And if you're having a day where you're feeling not quite right, you would have the tools to modify your exercise so that you could be effective and safe still. But likewise, if you're having a day where you feel fantastic, knowing how you could improve and enhance the exercise to really push yourself that little bit further. So we will often look at cognitive capacity as well so that we can tailor the exercise to the right level, but also give you the toolkit to be independent as much as possible at home. So you are constantly safe with what you're doing, but effective as well. Because what we find is most of the exercise that you will do is going to be done independently when you're not with a therapist, for instance. So you need a toolkit to enable you to be independent. And that's what we would definitely be looking at in a clinical capacity. Just wanted to touch on comorbidities quickly, just so that we're all on the same page. But there are comorbidities associated with age-related conditions, so independent of Parkinson's. Cardiovascular disease is a very common one. Just because you've got Parkinson's doesn't mean you're immune to any of these other metabolic, cardiovascular, respiratory problems, and that definitely complicates management for sure. So the fewer comorbidities, the better, and exercise is a brilliant way of staving off a lot of those. We've talked about autonomic. Psychiatric psychiatric changes with depression, anxiety, psychosis, that can be prevalent in the non-Parkinson's population, but the rates do tend to be much higher in Parkinson's as well. Exercise has been shown to enhance and improve management of most of those conditions, apart from psychosis. Diabetes, there is a link, it appears, between diabetes and Parkinson's, and especially type 2 management of diabetes is really important with exercise. So any of these comorbidities would be factored into an exercise prescription to make sure that you can manage your exercise and the output as much as possible. And I will just touch on pain as a separate issue here, because pain is very common in Parkinson's. You can see here from this particular study, 92% of people with Parkinson's did report chronic pain. That's huge. So you might note in yourself that pain is a really big issue for you. It does impact your quality of life. And if you don't sleep well at night and you are quite sedentary, I would probably posit that your perception of pain is enhanced as well. Because if you're not sleeping well, you're tired, all of those issues can become more pronounced for you as well. So there is benefit in having a really good night's sleep and earning your sleep through exercise so that you have more restorative sleep. That will typically have an impact on your perception of pain as well. People with Parkinson's related pain did typically respond to levodopa medication, and you might notice this in yourselves as well. When you're feeling on with your medication, you don't notice the pain as much. So all of those sorts of things would be really important to note as well. And we often see, excuse me, that pain can also be related to musculoskeletal changes. It's really common that people have shoulder dysfunction in Parkinson's, looking to see whether that's irritable, whether that's something that is rhythmic change, whether it's a muscle coordination change, and looking to the root cause of it so that we can improve that and reduce pain in as many musculoskeletal areas as we possibly can. All right, I won't labour that too much. I kind of have made the point already around levodopa. There is a huge place for levodopa. I'm certainly not advocating not using levodopa. I think levodopa is essential for your exercise routine and your program. If you're not on levodopa and exercising when you feel at your best, it's unlikely you'll get the benefits, the full benefits of training, because you won't be able to move as well to get those benefits. So levodopa is really important, but it is potentially a falls risk. It's that double-edged sword, particularly if you experience dyskinesias, it may increase your falls risk. So knowing that is really important so that you can manage that. But I just wanted to finish on a couple of real positives around falls prevention and how you keep yourself steady and stable in later stage Parkinson's. This was a large Cochrane review, which means kind of the highest level of evidence that can be gained. And it's typically pulling all the data from lots of different studies together. So this particular study ended up with 12 studies comparing exercise of lots of different types. And what they found is that exercise probably reduces the rate of falls by 26%, so nearly a third, which is fantastic. So we know that intervention can have a meaningful impact. In those that are already experiencing one or more falls, they found that exercise could reduce the risk by 10%. Now, when we think about falls, I've already mentioned the impact that it may have on confidence, but it also has an impact on every fall prevented prevents that risk of knocking your head, of a skin laceration, of hospital admission, all of those nasty things that take up so much time, but really have a big impact on your quality of life and certainly your confidence levels as well. So I just wanted to highlight that exercise can be very impactful in falls prevention. And hot off the press, I apologise, I noticed I just didn't put a reference here for this one, but this was an exploratory analysis that's just been published, Natalie Allen and colleagues, and they were able to show that a home-based intervention delivered over a span of 6 months with a combination of occupational therapy and physiotherapy were able to reduce falls by nearly 50% in the 6-month follow-up period. So this is huge. This is really exciting. And so what we're looking at here is how we can derive the benefits of studies like this and make sure that we put these into very proactive falls prevention programs to make sure that you are as safe and steady and effective at home with your exercise programs as possible. All right, so I've done a lot of talking at you. I apologise, and I have run over, but I can't help myself sometimes. So I'm going to finish there. I do just want to touch on Insight, because there's that study I just showed you will be presented at Insight, which is fantastic, as well as 30 other speakers across the 2 days. There is so much great content to come and listen to. If you like the convenience of watching good quality education from home in the convenience of your lounge room, by all means, sign up, register. We'd love to see you. It's free for the first 24 hours per day. And if you do choose to purchase an upgrade, you can do that. You'll have 50 days to access all of the content. And the great news is that all of our ticket proceeds are donated to our charity partners, of which Parkinson's New South Wales is a beneficiary and a charity partner. And we are, as Stacey said, going into our 9th year. And to date, we've raised close to $250,000 through those ticket proceeds. That has all been donated. So it's a great cause. We hope to see you there. The details are down the bottom there of that sign there, pdwarrior.com/insight. So I hope to see you there, and happy to answer any questions.